Hi everyone, thank you for joining us for our webinar, Optimizing Brain Performance with Physical Therapy and Neuromodulation. This webinar will focus on evidence to support the use of neuromodulation and PT to improve cognition and attention in patients with conditions like TBI, stroke, Parkinson's, multiple sclerosis, and others. And of course, how NeuroCatch was used to monitor these changes. I'd like to take some time to introduce our two speakers today. Our first speaker is Dr. Nicholas Moser. Dr. Moser is a practicing chiropractic specialist currently working at the Toronto Rehabilitation Institute in the KITE research clinics. Dr. Moser graduated from the University of Ottawa with an honors Bachelor of Science degree. After completing his undergrad degree, he attended the Canadian Memorial Chiropractic College, CMCC, and completed his degree. Dr. Moser then completed a postgraduate fellowship in clinical sciences at CMCC. During his fellowship, he evaluated the changes in blood flow in the brain and neck before and after manipulation in patients with chronic neck pain using fMRI technology. This work can be found in the British Medical Journal. His clinical experience includes internships at Mount Sinai Hospital in the Rebecca McDonald Center for Arthritis and Autoimmune Disease and at the St. Michael's Hospital in the Department of Family and Community Medicine. Dr. Moser is currently undertaking his PhD at the University of Toronto through the Institute of Medical Sciences. He's currently running a randomized clinical trial out of Toronto Rehab. The trial is focused on better understanding ways to facilitate healing following a concussion in those whose symptoms persist beyond normal healing times. Our second speaker is Dr. Ryan Darcy. Dr. Darcy is a neuroscientist and neurotechnology entrepreneur. He is the co-founder, president, and chief scientific officer of HealthTech Connex. He holds professorship appointments at the Simon Fraser University and the University of British Columbia, where he serves as a BC Leadership Chair in Neuroimaging and Neurotechnology. Dr. Darcy has led the development of numerous innovations to improve brain health, including the Health and Technology District in Surrey. He has published more than 275 academic works, attracted more than 100 million in competitive research and innovative funding, and has been recognized through numerous awards and distinctions, such as Canada's Public Service Award of Excellence and BC 500 Influential Business Leaders. Dr. Darcy is a 3-time TEDx speaker who speaks frequently on brain health innovations around the world. And with that, I will turn it over to our first speaker, Dr. Nick Moser.
That we're seeing and the changes that we're making. So I'm going to run us through that wonderful article that was recently published in the Frontiers, and I'm also going to briefly touch on what's going on over here at KITE Research, which is where I am today. So without further ado, let's get started. See how I can click this next. There it is. I just have one disclosure to make before we do begin. As you can see on the bottom, the banner there, I'm very fortunate to be having granted a nice grant from the MyTax program, and NeuroCatch is a partnered organization. That's my one little disclosure here today, a little conflict. I already kind of summarized what we're going to go through, but just again, to keep everyone on pace here, we are going to review that Frontiers article, the rationale as to why it was conceptualized, the methodology, and run us through the results. And then I'm going to shift gears, and because I have this form, I'm going to just run us through what we're doing here at KITE, and that is we're running a clinical trial, and I'd love to update you guys on that. And we have the privilege to kind of tell you about the responses that we're getting with the first few subjects that we've run through. If at any time anyone has questions, please ask, and I'll do my best to try to interject. Otherwise, we'll circle back, I'm sure. This is one of my favorite patients ever. Scott was an absolute warrior, and he was such a wonderful person to work with. He came to see me in Oakville when I was practicing there, and he had suffered a stroke approximately 12 to 15 months. It's been several years since I saw Scott, but it was around that time frame when he presented to the office, and he presented because he had heard we were using the PONS therapy program, and he was wanting to improve his life in terms of his strength, his mobility, and just being able to engage in activities of daily living. And so the image you see on the left is always giving a thumbs up. He always got a smile. He was ready to work. We were scanning his brain using the NeuroCatch platform, as we do with the PONS program. And on the right, you can see him engaging in the PONS program. So I will show a better picture, but you can see the white device around his neck, and there's an electrical device on his tongue, stimulating the cranial nerves and helping him with the physical therapy program. Now, I'm sure there's a lot of clinicians in the room from what I was told. So briefly, those who are not familiar with the PONS program, it is an intensive 14-week program designed to really kickstart people's recovery in terms of gait and balance. So it's really focused on the physical. But this patient is a real representation of those in the journal paper. That is, he was a stroke victim, and he was coming for improvements in physical function. Yet within 4 to 6 weeks, he had noticed significant improvements in cognition. Specifically, one day he came in and he said, I don't know what's going on, but I'm able to read a book again. So when he first entered the program, his real passion was reading, and he couldn't read. He couldn't sustain attention. Specifically, this is going to come up again. So he couldn't sustain attention for more than a few minutes. So obviously he couldn't get through a chapter, and that was very discouraging. But just after 4 to 6 weeks of the PONS program, he was ravaging through books back to where he used to be. So he was quite happy, along with the physical advancements that were occurring. And I think this is what really, like I said, spurred this paper. Because clinicians are around the world using this PONS therapy program. And Dr. Darcy might speak to it, but there have been several trials of healthy participants noting improved cognition with this translingual neurostimulation. And so we can see the PONS. This is a little bit better picture of the PONS device. So it hooks around the patient's neck, and then that electrode is onto the surface of the tongue, the anterior 2/3 of the tongue. So it stimulates cranial nerves 5 and 7. But it also co-modulates areas in the brainstem. So we get improvements in the vestibular, visual, and other forms of improvements that we're seeing, specifically as we'll get into cognition. So this was a really nice trial in the frontiers. That is, not only did we investigate stroke, it was investigating on mild and moderate traumatic brain injury, Parkinson's disease, Alzheimer's, and others. So it was a real healthy population sample to assess the effects that this intensive physical therapy plus stimulation was having on cognition, specifically attention. So the methods were simple. It was retrospective review of about 33 participants, like I said, different clinical conditions. So patients had a NeuroCatch at the baseline entry of program, and after 14 weeks of the intensive therapy. So this is not a participant in the study, but just to give you a little flavor, this is actually one of our participants in the clinical trial, post-concussion clinical trial. And this is on the right, as you can see, is just a radar plot of what we kind of get from the EEG scan, the NeuroCatch scan, the ABCs they're called. So we have the N100, both its strength, amplitude, and how quick it goes, the latency. We have that for N100, which is when your brain hears something. P300, when your brain is detecting differences in noise. And N400, which is a higher level processing, more language processing. So when patients, it's maybe hard to see in the photo, but this patient has headphones in, and so she's listening to a recording, and the recording is of tones or of change in words, word pairing. So they're either congruent, peanut butter jelly, or incongruent, peanut butter plain. So you're like, what the heck? That didn't make sense. And so the detection of these, of the brain occurring is what happened with the EEG, and these are what we get. Move into the results. So that radar plot is built off of these waveforms. I'll try to walk us through here to make sure everything's clear. On the top, we have the N100 and P300, and on the bottom, we have the N400. On the left of the screen, we have the baseline, so when they enter the program, and on the right of the screen, we have the endpoint, so when the patients were done the PONS therapy program. What I hope you can appreciate is if you look at the blue dot, the N100, pre-post, you can see the significant change occurring from baseline to endpoint in both the time and in the condition. So the black line represents the deviant waveform, and the gray line is the standard waveform, meaning the tones they were hearing. So the standard tone, and then one tone didn't sound the same. So the registration of that is what we're detecting. And it appeared that on average, there was a significant change in selective attention in these patients. There was no significant change to the P300 and N400, but if we move forward, we see also a significant change in the N200. So these primary outcomes were showing significant changes, specifically in patients' ability to have selective attention. So beyond the physical performance changes that were observable, something's happening to patients' cognition. And that's what it appears. So intensive physical therapy with translingual stimulation in both the healthy and in the clinical population, there appears to be improvements in cognition, specifically attention. And this study, it helps to add to the growing body of literature supporting these neuroplastic changes that we're seeing as clinicians. There has to be something more, and I think we're starting to be able to see this because patients are reporting these changes, and finally we're having a platform through the NeuroCatch via the brain vital signs to actually objectively assess and have sensitive markers to changes in patients' cognition. I think this is a huge step forward. I'm going to switch gears here just because of my time, and I'm going to switch into what we're doing here at KITE, which is kind of building off of this idea. So we're running a randomized clinical trial investigating the effects of individualizing patients' care who have persistent concussion symptoms. So this is a little bit of an overflow of what we're doing. So keep in mind here for the clinicians in the room, if you want, we're still accepting referrals. So the referral process is ongoing here at KITE. Patients are being referred from various head injury clinics and just general clinics around the GTA. They come in for a standardized assessment that I perform here at the KITE clinic. And it's an examination that has been outlined by the University at Buffalo. Specifically, those in the room here understand Dr. Letty has been influential in the publications for concussion and persistent concussion symptoms. And they outlined specific tests that should be done as part of a standardized exam, including the cardiovascular fitness test. And it's through this examination that we can subgroup our patients into specific groups that we think are driving their symptoms. Our primary outcome is we're looking for changes in this Rivermead post-concussion questionnaire, which is just a validated questionnaire with 16 different symptoms that patients can experience. And they rate them from not experienced at all to severely affecting. And our secondary outcome is the NeuroCatch Platform, looking for changes in cognition. We're a very broad acceptance. Really, the only exclusion is if symptoms have not been there for more than 4 weeks or they're persisting beyond 1 year. For those not familiar with the crossover trial, this is a nice little depiction of it. So we're aiming to get 50 participants. We're at 8 so far. These participants are randomized to receive either the individualized care or the usual care first. And so for example's sake, let's just say Terry gets randomized to individualized group A. So for 6 weeks, he's going to take the individualized care, and we'll get into what that is in just a moment. After 6 weeks, we run through those assessments again. So the standard exam, the RPQ, the Rivermead post-concussion questionnaire, and the EEG. After that 6-week mark, he then would undertake the usual care for another 6 weeks. And at that 12-week mark, we would perform our final endpoint assessments. So this is pretty much the bread and butter of the treatment. I'll try to run us through here to make sense of these pictures. But the individualized care program is basically 3 pillars of health. The top 3/4, okay? It's hard to just choose 3 because there's so many things that are so influential in patients' recovery. For the clinicians in the room, they know that. But the top is mindfulness-based therapy. So patients are advised to perform 10 to 15 minutes of breath work or mindfulness-based training every day. And I also need a caveat here that because depending on the subgroup, it's individualized. So some patients are not receiving some of these therapies, but just to give an overall sense of what is being provided. I said /4 because I feel that picture on the top also does represent sleep. Sleep is one of the most fundamental things that we've found has the greatest impact on patients' recovery. If you're not sleeping properly, then all this rest, the rehab, the meditation, the pain medications, they're not going to make the changes that we're looking for. The second component is cardiovascular training. In the individualized care stream, patients are specifically provided with a heart rate target to exercise to. And this has been fundamental for achieving recovery. So patients are on the standardized assessment. We find that level where their heart rate is, if it exceeds, they have symptom exacerbation. And about 90 to 80%, depending on the patient, we get them to exercise daily at that level, that heart rate marker. And the last component of individualized care is manual therapy. So that looks like that gentleman with the yellow t-shirt is providing some manual therapy to the upper back and neck. So that person maybe had a cervical disorder. If they had oculomotor issues, it would be oculomotor training. Vestibular issues, vestibular training. We compare this to the usual care, and I think it's augmented usual care because of how intensive we allow the patients to come in for weekly supervised exercise sessions. And this includes cardiovascular conditioning, cervical spine conditioning, rehabilitation, and vestibular oculomotor rehabilitation should that be necessary. I'm happy to share the first 3 participants that have run through the trial. The full 12 weeks, I only put here 6-week follow-up markers, but they didn't really change much after the first 6 weeks. It just says my internet connection is unstable. I hope we're still good here, Victoria? Okay. So what we can see, so these 3 patients were quite complex. The first one had 2.5 months symptom duration. Our second patient, 39-year-old male, 4-month symptom duration. And our last patient there, a 61-year-old female, 3.5-month duration. Each of these patients had undertaken at least 2 months of therapy prior to undertaking the clinical trial with no improvements. The first patient was a motor workplace accident, and the following 2 patients were sports injuries. We can see that the RPQ stands for that River Post-Concussion Questionnaire, and it's broken up into 3 and 13 because the 3 is more the physical symptoms patients experience, headaches, dizziness, and the 13 is more cognitive, affect, mood, such as brain fog, difficulty thinking, anger easily, things like that. The PHQ-9 is another metric we were looking at. It's a secondary outcome, and it's a standardized, validated questionnaire to provide the general population to assess degrees of anxiety, depression. And I've highlighted the things that I think are quite important. You can see the RPQ-3 on each of these individuals was quite high. It's very difficult to score this high. They were suffering from severe headaches and dizziness. And also you can see the first 2 participants there, they had 20 out of 27 and 25 out of 27 PHQ-9 scores. Just for reference, over 15 is significant for a likelihood of major depressive disorder. So the first 2 participants, apart from the last one, were suffering from significant anxiety and depression because of their symptoms. Unfortunately, I can't provide you much with the NeuroCatch scans because these 3 participants had normal NeuroCatch scans. But as you can see there at the 6-week follow-up, after the individualized care, we had significant and clinically meaningful changes in all metrics. So one thing to note is now that drop from the PHQ-9 from 20 to 5 on both of them, there's something more than the physical going on. We're affecting cognition and we're affecting mental health through exercise and proper physical therapy. This last patient, this is a patient 4 that came in. She actually had a slight positive score on her NeuroCatch scan. So 32-year-old female with persistent headaches for 5 months duration. And she was diagnosed after the standardized exam of only having a cervical disorder, post-concussion syndrome. So she passed the treadmill test, no autonomic dysfunction, nothing wrong with the vestibular system of the eyes. After 6 weeks of the usual care, so she had intensive cervical spine reconditioning.
Nick, I'm just going to interrupt you for one second. You are breaking up a little bit.
Yeah.
If you mind turning your video off, usually that makes the audio a little bit clearer because it's less bandwidth. And just start a couple, 30 seconds back.
Yeah, no problem. Thank you for that.
No problem.
Sorry about that, guys. I think I said this 32-year-old female, she's 5 months, she came into the program. She was randomized to the usual care. And through the standardized assessment, we found that her only impairment was cervical spine disorder. So her headaches, her cognitive fog was being likely caused from a cervical spine impairment. So she was, like I said, randomized to usual care. So she undertook the 6 weeks thus far. And we can see pre-post scans. So the baseline is the dark blue. That's when she first came into the clinic here. And the light green is after 6 weeks. So the non-significant, but the change that we observed here was the P300, the latency specifically. So we can see her amplitude is quite low. So the strength of the response to the deviant tone when she's listening to the recording is not very strong, and it's happening quite quickly. So we're hoping to normalize this, as the P300, as Dr. Darcy may speak to, is very significant in the concussion population. And be it this has just been the first 6 weeks, she's undertaken about 4 weeks of individualized care, and the headaches have considerably improved further. So I'm interested to see how her NeuroCatch scan changes from there. But this is just to show, again, without the translingual stimulation, intensive physical therapy is seemingly to have effects beyond the physical and the sensory and motor, and starting to impact the cognition and beyond. So I think these are very exciting things that we should be keeping our minds on. And I'd just like to sincerely thank everyone for their time, and hopefully we get some good questions afterwards. But I'm going to turn it over to Dr. Darcy, and he can take it over from here. So I'm going to stop sharing. Figure that out.
Thanks, Nick.
No problem, buddy.
Just seeing if it looks like I'm still displaying your screen.
Yeah, maybe click stop sharing screen, Nick, and then it will allow Ryan to share his.
For sure. It says resume sharing. This is so embarrassing. Maybe I better open this up. Nope. Leave meeting info. Yeah, I'm more like a boomer, not a generation.
So click on the where it says share screen and the green arrow. Just click that, and it should stop sharing.
There it is. There it is. You're the best preparer. Thank you. Thank you.
No problem.
Sorry, guys.
Oh, fabulous. Now I'll just confirm to see if my slides are being shown.
They are.
Yay! Awesome.
But you can go into presentation mode if you prefer.
I beat you.
There you go.
I was there already. It was the computer that was slow.
Uh-huh.
All right. Well, thanks everyone, and that's an awesome setup. As Nick, you just crushed it. So you've made my job easy. So thank you everyone for tuning in. I too will try and sort of hit the 15-minute mark and leave time for questions. So I'm going to just pick up where Nick left off. And the goal for this talk is really to give you a little bit more of depth in terms of NeuroCatch and it's the work around attention and cognition for the paper. And then also to move to showcasing a clinical case study example that I think really drives the point home of this incredible connection of doing physical therapy with the ponds and seeing improvements that are watershed effects in cognition and attention. As Nick did, just a quick disclosure. So in addition to having my professorships here in BC, of course, NeuroCatch is a technology that we have created through HealthTech Connex. And in fact, for those who are interested, NeuroCatch is one of the 3 entities within HealthTech Connex that allows us to measure. We have a Center for Clinical Trial, Center for Neurology Studies that actually does clinical trials that also look at new treatments. And the birth of that center was actually through the early work with the ponds. And we realized we could look at a lot of new innovative interventions and curate them in an evidence-based science framework. And so that's a center I'd encourage you to pay attention to. And for those folks that we want to get early access to these impactful treatments, we also run a Surrey Neuroplasticity Clinic, which is an amazing neuro rehab clinic that is really a real world clinic and was one of the participating centers for this trial. So the article, which is we always try to publish things in open access. So this is a link click away, a Google search away, if you will, in Frontiers in Human Neuroscience. I think I just want to feature a couple cool things about this article. The first is in the title. It was real world evidence. So there's lots of controlled clinical trial evidence on the ponds. There's some experimental evidence I'll be showing you. I really liked this study because it was clinical patients being treated that we then came in and looked at the effects of cognition while they were getting physical therapy treatments. The other thing I'd probably highlight is that makes this worth paying attention to is as Nick and I are demonstrating, It's a multi-site study. So it was patients being treated both in Vancouver and Toronto. So I think the fact that these effects spanned these two clinical centers really speak to the robustness of the effects that we're seeing. So I'm going to back up a bit. In that article, we review some of the research that led us to this point. And this article, I'd encourage you, again, it's open access. I've included the reference at the top there. It's work back in 2019 published, where we started actually based on, as Nick rightly said, there were clinical observations that while you were working to improve balance and gait, clients and patients were reporting improvements in cognition. So we got curious about that, and we actually took 20 healthy individuals, and we just did PONS activation. So there was no physical therapy. All we did was actually have them in a similar crossover design as what Nick just showed you, do PONS where they would have a baseline with the device in their mouth but not turned on. And then they would have 20 minutes of stimulation. And then they would have 20 minutes where the stimulator was turned off, but presumably the effect would continue. And we actually did two doses. We did a high frequency, which is the main therapeutic dose, and then we did a lower frequency, which still stimulates and causes impacts. So we were kind of in the crossover design. We were interested to see if these things were impacting attention and cognition. And you can see in the lower left-hand corner, we did this was high density EEG, so we could look at the spatial changes and we could look at the maps to see there are specific spatial topographies that are called microstates that are associated with verbal, visual, autonomic, and attentional changes. And what we did see early on is we saw some attentional changes. You can see it in the figure with a significant difference between the baseline and the post-stimulus. And on the top there at the high frequency dose, the red line is actually the attentional line. And from baseline, it lifted up during stimulation and sustained even after you turn the stimulator off for 20 seconds, or pardon me, 20 minutes. So that was kind of our first clue that PONS activity in general is probably driving your attentional systems. The second clue in this paper was actually we could see significant changes in both alpha and theta. And the lower right-hand corner is actually probably the muddy figure here. This is the most interesting one. These are the spectrograms of the frequency changes. And what you're looking at is both the high frequency and the low frequency and the high frequency. And then they're actually crossed over and tested 2 weeks later. And what I want you to direct your attention to is that red band of activity in kind of the alpha range of the frequency. And you can see in the lower high frequency group, it's much darker and much more higher alpha than in the low frequency group. So what was kind of interesting here, of course, you see that continues even after the stimulator is off. But when we got them back a week later and we crossed them over, the real finding that caught our attention here was that there was some sort of biological memory for what dosage of PONS intensity you got. So if you were in the low frequency group and then you got crossed over to high frequency, your level of alpha intensity via that red band never got up to be as high as if the first stimulation you saw was high frequency. Whereas if you were in the high frequency group and you got crossed over to the low frequency, when you got the low frequency dose, your brain received it at the same alpha level as when it got the high frequency dose. So that result suggested that in addition to attention, the PONS neuromodulation was changing things in a way where your brain had some form of biological memory. Another study we did was actually to look at when we paired the PONS stimulation with cognitive skills training. And this is just a quick paper. Again, I'm showing you the reference so you can take a photo of that or take the details down. Open access, again, in Frontiers in Human Neuroscience. What we did here is we compared a group that had cognitive skills training while they had PONS stimulation with a group that didn't, a control group that just had cognitive skills training. And these are just the cognitive processing N400 results showing you the increase in the N400 amplitude, the sustained amplitude in the group that got PONS treatment. Whereas in the group that didn't get PONS treatment, there was in this generation of the N400, there was actually a small habituation of the effect. So in this paper, what we could see is that PONS seemed to have a specific effect in cognitive attention and vigilance, allowing your cognitive vigilance to stay high while you were doing cognitive skills training. And of course, Nick has done a really good job outlining this most recent paper where we moved from healthy individuals and basic fundamental neuroscience studies to look at specifically what I think is really nice is a real world, largely TBI patients, but then also patients in stroke, Parkinson's disease, multiple sclerosis, and others across 2 centers. And he's showing you that the main changes in this study were both in the N100 and the N200 as a consequence of the neuromodulation in these groups, these patients being treated for balance and gait. The one other thing that we were actually, this is a little peek inside the analysis, if you will, we were actually looking closely at 2 things. Number one, these clinical findings paralleled a significant improvement from baseline to endpoint in CogBat scores, so in our clinical anchor measure. But the other thing is that we were looking at the N400 as well, because we were seeing changes in the N400 where there was an improvement in the latency. Unfortunately, those changes, because of the small sample sizes, good sample size for a clinical sample size at 33, but it was still pretty small and it was a heterogeneous group. And so we couldn't pull that out in terms of statistical variance, statistical significance. It was close, but it wasn't close enough. But you can actually see if you compare the N400 between the baseline and the endpoint, there is an improvement in cognitive processing speed, which matches some of the stuff that I've just shown to you previously. So now just a little bit more about the science behind NeuroCatch. The concept of the science behind NeuroCatch is really to get into that we can get an objective vital sign for brain function. And we can derive that from these 3 components, this auditory sensation N100, this P300, which is basic attention, and this N400, which is cognitive processing. This slide is really to give you a sense that we actually started translating this work and publishing it actively since 1995. So this is not a new area. It's intentionally focused on translating capabilities that are in our research labs out to the front line of the clinical point of care, like what Nick is using today. So basically, the concept behind NeuroCatch is to make it deployable, to make it automated so it's push button. So whoever does the test, it's the same result, and we get standardized normative data. To make it intuitive, you've seen the radar plots, so we pull it out of the waveforms and pull it into an intuitive radar plot format. And to compress it to what would be 2 to 3 hours in a lab into a rapid 5 to 6 minute test in the clinic. And of course, we intentionally built this off of EEG and evoked potentials to keep it such that it was economical and affordable. NeuroCatch today is in its 2nd generation. It actually is Class 2 Health Canada approved, and its low risk allowed it to be registered for approval in the FDA. And probably one of the most important things that seems to help is that the report is immediately available and therefore immediately actionable. And so it's providing us, as Nick nicely showed, an ability to look at changes in cognition on the front line. This is just a picture of the system as it is. Nick showed you an excellent picture. I'll just flag that the device itself is up in the upper left-hand corner. It's a little bigger than a cell phone. We still do use a cap with sensors because we will not compromise on quality. And the device itself is 10 to 15 times more sensitive, that is more precise, than any available system out there, because of our EPIO technology, where we've solved a long-standing technical problem and got ourselves an incredible sensitivity to true sensitive changes in what's happening in people's evoked responses. So I'll finish just with a quick foray of a case study that I think drives the clinical point home of why it's relevant, why it's important to start thinking about when we're treating in terms of physical therapy and looking at things like balance and gait. We should be thinking about improvements in cognition too. As many might know, our team have been active in helping Captain Trevor Green and Debbie Green recover from being attacked in Afghanistan in 2006 by an insurgent who drove an axe into the top of Captain Green's head, transecting the body of the corpus callosum. So probably unofficially surviving the largest brain injury that I've personally know and have seen. This is a picture of Captain Green standing. I like to lead with outcomes first. So this is him standing independently the eve before he gave a TEDx talk with myself, and certainly would encourage you to check that story out. We've been working with Captain Green in an advanced rehab capability over many, many years now to get him to continue to improve his ability to regain his physical motor capabilities, standing in his lower limbs, and also his upper limb capabilities. This is a very well-documented story showing how we were using advanced imaging like functional MRI, as you can see in the center, to track through the red increase of activation his improvements in recovering function, motor function, primarily in his lower limbs. We've been using lots of different technologies, such as an exoskeleton, as you see here, to help give him an assist. But by far and away, it's been by monitoring the changes in his brain over time and using the PONS that we've been able to break through in a much more impactful way. So I'm going to show you a little bit about what we got first in functional MRI to set the stage for how powerful the PONS is. This is early work we published showing basically in the top panel that Trevor Green, intensively doing physical therapy every day of the week, was able to, using fMRI, increase his motor function and his motor, and fMRI could map the increase in the motor activity. What you're actually looking at is a 3-year study. Each line on the top panel is him in the MRI trying to move his legs. And what we can see is that over the course of that, we got increased activation such that clinically he was starting to be able to stand himself to get into the MRI. He stood to take his wedding vows around time 7. He was then actually taking his first steps in parallel bars around time 9. And by time 12, with assist, he was doing laps of a long span with a walker. Interestingly, scientifically, we compared that to him imagining moving, and we could see he was activating the same areas, but they weren't increasing linearly, which was a really good test of a control condition within him. And we also compared against a matched control. So then he hit a bit of a plateau where his best intensive efforts were not enough. And we rolled in the PONS, which had just come out of this large, I believe it is to date still the largest clinical trial for neuromodulation ever done. It was a multi-site trial that our team, our CNS team in particular, was critical in helping, and got, I believe it was half the patients in nearly twice the patients in nearly half the time, and really did drive this technology to becoming successful. In this clinical trial, with some of the anchor evidence where we could show that mild to moderate chronic TBI patients, 67.2% of them showed a significant increase in balance. Secondary outcome measures such as falls were also significantly reduced with using and incorporating the PONS. But the key thing we noticed, as is the point of this, is there was potentially evidence of additional cognitive. So what we did with Trevor is we actually did a 2-year study. The first year, we used intensive physical therapy without the PONS. And we measured his time stand and his function in sitting test. And the time stand is really, we saw it in both, but the time stand really tells the tale. Over the course of a year, no matter how hard we treated, we could not get Trevor to stand more than 2 to 3 minutes independently. When we turned on, if you look at the lower left-hand corner with this baseline 1, 2, and 3, that's the time stand data. When we put the PONS into a 14-week protocol, really rapidly, within weeks, I came into clinic and he was standing independently at the 20-minute ceiling. We could see this change in terms of his electrical activity in his right and left hand also improving. And I won't go into the nitty-gritty of these MEG's findings, but just to show you that when we kick it up with really hardcore brain imaging and we look at the clinical tests relative to the changes in his brain, in his upper limbs, we could actually visualize that in his more impaired right limb, he was deactivating transcallosal inhibition to regain function. In his more functional left limb, he was activating his premotor strips to gain more function. So from a physical therapy point of view, we were not only seeing time stand improvements, but we were seeing upper limb movement improvements, and we could track that using advanced brain imaging. But the real tale of the tape is when we looked at his NeuroCatch data. So as you can imagine, with an axe injury going through the body of the corpus callosum, his cingulate gyrus was also impacted quite severely. And cingulate gyrus is really important for attention. And so he's had a long-standing challenge with attention. And here, similar to what Nick just showed you in his patient population, we saw the amplitude of the P300 was significantly reduced over that 1-year baseline period. And when we turned on the PONS treatment, we could track a significant improvement in the P300 amplitude all the way back to normal healthy levels. Now, the heartwarming part about this project is at the same time, synchronous to this, both he and his wife, Debbie, reported dramatic drops in his post-traumatic stress disorder. His night terrors went away, and they've stayed away since. I saw him on the weekend. He still does not have night terrors anymore. And he's got much more manageable to sit to his back in a public place. So what we saw here is we have to clinically think about neuromodulation at a whole brain, whole multifactorial level, even when we're treating from a point of view of physical therapy. And I'll tie it off there. And hopefully that was in time, and we've left enough time for questions. Thank you.